سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we are continuing the pediatric imaging series. We have finished with the brain normal anatomy, imaging of the hydrocephalus, imaging of neuronal migration disorders. And we still have some of the important issues in the brain imaging. And this is one of them, which is dealing with imaging of the pediatric brain tumors. This is actually a very long subject, and I will handle it on two separate lectures. And the first one will deal with some of the posterior fossa and supratentorial tumors, and after that we will continue with the other imaging with the other tumors. And these are the issues we would like to expose. The first one is the posterior fossa tumors, then the supratentorial tumors, then intraventricular tumors, then the supracellular lesions, and biennial body tumors, congenital tumors, and finally we have the cystic lesions, which are considered tumor-like lesions. And starting by the posterior fossa lesions, we have a lot of space occupying lesions or tumors that can occur in the posterior fossa. And the most common, of course, is the ependymoma and the medulloblastoma. But we have also the brainstem glioma, the pilocytic astrocytoma, the angioblastoma, and the trigeminal neuroma. Also, we will say something about the primitive neuroectodermal tumors. First, we discuss the common posterior fossa tumors in the pediatric age group, and this is one of them, which is the ependymoma. Ependymoma represents about 9% of the gliomas. It is of a relatively high grade, and it represents about 10% of the pediatric intracranial neoplasms. The age incidence of ependymoma is around the 10 to 15 years old, and as you know, it is more common in children than in adults. And this tumor is located in the region of the fourth ventricle, and commonly you will see a mass in the midline posterior fossa region centered to the region of the fourth ventricle. And this mass will show the criteria of the tumor being an enhancing lesion, and it may contain calcium, and it may show some vessels within the tumor. And you know that ependymoma can occur along the central nervous system, starting from the filum terminal to the spinal cord, intramedullary, and the supratentorial, then the posterior fossa. Posterior fossa lesions have the worst prognosis of all these types of ependymomas. And ependymoma will show a mass which is of relative isodensity to the brain parenchyma. It is located in the midline region of the posterior fossa, centered actually on the fourth ventricle. And this is one of the common lesions that can show calcium in the posterior fossa, and the calcification ranges between 40 to 50% in ependymomas. Then whenever you inject the contrast media, you may get homogeneous or heterogeneous contrast enhancement. And because of its strategic location being centered to the fourth ventricle, then the CSF flow will be obstructed, and the patient usually have supratentorial hydrocephalic changes. And this is one of the well-known lesions that can spread by CSF. Then you can see CSF seeding or seedling within the supratentorial extraaxial CSF spaces. Some of the cystic changes can be seen in the tumor in the range of 15% of the cases. And one of the a classic criteria of ependymoma is that its ability to creep within the fourth ventricle and extend through the outlet foramina of the fourth ventricle by somewhat extensions which are not seen in the rest of the tumors occurring in this area. And this is a case of ependymoma centered to the fourth ventricle, and the supratentorial scans showed enhancement of the quadrigeminal cistern, enhancement in the superior cerebellar cistern, and these nodular enhancement represent CSF metastatic spread of this tumor. Ependymoma by MRI will be similar to any of other tumor, being of relatively iso to hypointense in the T1 and some increased signal in the T2 weighted images. And if you inject the contrast, you may get homogeneous or heterogeneous post-contrast enhancement. And you remember the incidence of intratumoral cystic changes, and this is an example, which is in the range of 15%. Then the primitive neuroepithelial tumors are a group of tumors. Histologically, they have undifferentiated cells, and this group includes many of the known and unknown tumors like the medulloblastoma, the retinoblastoma, ependymoblastoma, medulloepithelioma, and cerebellar neuroblastoma. Actually, there are no specific criteria to diagnose these particular primitive neuroectodermal tumors, but these are the criteria mentioned in the literature. They have a peak in the pediatric age group and another peak in young adults, and they are very highly malignant lesions with high incidence of CSF dissemination. And one of the criteria is that these tumors are able to produce or give metastasis outside the CNS, maybe to the bone, as you can see here. Then these tumors are usually solid. They do not contain cystic changes nor calcium. And these are considered atypical findings if you see cystic changes or calcification. And medulloblastoma is one of these primitive neuroectodermal tumors. They represent about 25% of the pediatric intracranial neoplasms, and the average age of incidence is about 7 years old. You know that medulloblastoma arises from the roof of the fourth ventricle and in this particular area. So it can grow inside the ventricle and also has a component within the cerebellar parenchyma. This is also a midline lesion which is centered to the region of the fourth ventricle. And the fourth ventricle is usually obstructed and you got supratentorial hydrocephalic changes. Also, there is an incidence of calcium, but it is much less common than calcium within the ependymoma. Then, calcification in the medulloblastoma is in the range of 15%, and this tumor also produces CSF metastatic seedling similar to the ependymoma. Then you see an enhancing tumor midline in the posterior fossa, and this tumor is encroaching on the back of the fourth ventricle, and this is the fourth ventricle which is dilated with supratentorial obstructive hydrocephalic changes. And this is another case of a medulloblastoma, almost totally centered over the area of the fourth ventricle. And this is a case of medulloblastoma by MRI T1 weighted image, a relatively low signal lesion, and this is the FLAIR imaging, so showing some increase in the signal, and after contrast enhancement, then you got a homogeneous or heterogeneous contrast enhancement. Then if you look carefully in this image, and you can see enhancement along the anterior and posterior walls of the spinal cord, and this is diagnostic of CSF tumor spread. Then one of the criteria which may help you to differentiate between ependymoma and medulloblastoma is the sagittal MRI images. And the ependymoma usually totally obliterates the lumen of the fourth ventricle, especially this upper part of the fourth ventricle, while the medulloblastoma is encroaching on the fourth ventricle, and in many cases it leaves this area of the fourth ventricle unobstructed. This is not a solid rule, but it can help you to differentiate between ependymoma and the medulloblastoma. Of course, the age incidence in the medulloblastoma occurs at a younger age, a relatively younger age compared to the ependymoma, and also the incidence of calcium in ependymoma is much higher than the incidence of calcium in medulloblastoma. But the cystic changes in medulloblastoma have an incidence of about 65% compared to the incidence of cystic changes in the ependymoma, which are in the range of 15%. This is a case of medulloblastoma showing cystic changes of low signal in the T1, high signal in the T2, and the solid component will enhance heterogeneously after injection of contrast. And in the sagittal images, and you can see the tumor filling and encroaching on the fourth ventricle, and you may see this part of the fourth ventricle unobliterated by the tumor. This is a case of medulloblastoma by CT. Then you see calcium within the tumor. You see supratentorial hydrocephalic changes. This is MRI T2 weighted image, and you see the appearance of the lesion. And after contrast, this is sagittal T1 post contrast image showing the tumor encroaching on the fourth ventricle. And you see this sign, which I repeat, it is not a solid rule as a differentiating point. Then we came to the brainstem glioma, which represents about 12 to 15% of the pediatric brain tumors. And you know, this lesion affects mainly the bones, and it can spread up and down. And the main presentation of the brainstem glioma is by cranial nerve pulses, especially the sixth one. Then this is the appearance of the bones, normal appearance of the bones and normal appearance of the fourth ventricle. And whenever the brainstem is infiltrated by the tumor, the brainstem is markedly enlarged, and you got flattening of the anterior aspect of the fourth ventricle, which is displaced posteriorly, and consequently you get supratentorial obstructive hydrocephalus. And one of the very important criteria of brainstem glioma is that it can have an exophytic extensions. The tumor grows by exophytic extensions on both sides of the basilar artery. You know that the, the tumor, if it leads to a swelling of the brainstem, it should displace the basilar artery anteriorly. But the opposite occurs with the brainstem glioma. The tumor grows in front of the basilar artery, and then the basilar artery is displaced posteriorly. And this is one of the important criteria differentiating brainstem glioma from any other lesions that can occur in the brainstem. Then you know that brainstem glioma 50% do not show contrast enhancement, and they are considered of lower grade in malignancy compared to those that they are enhancing. If enhancement occurs within the brainstem glioma, they consider the most aggressive type, which is glioblastoma multiforme. And here is an example of brainstem glioma in the T1, T2, and T1 post contrast. The tumor is showing some contrast enhancement, and meaning that it is of aggressive nature. And you can see the very important sign of exophytic extension of the tumor by limbs anterior to the basilar artery, which is displaced posteriorly. The basilar artery is patent, as you can see by the signal void appearance in all bulb sequences. And the flattening of the anterior aspect of the fourth ventricle is also one of the important diagnostic criteria. And this is the rest of the images, T2, and this is the flare image, and this is the diffusion weighted image, and it shows no evidence of restricted diffusion. And pilocytic astrocytoma is one of the common lesions seen in the posterior fossa of the child. The characteristic appearance by CT and MRI is the presence of a cyst, and inside the cyst you see a solid nodule which is enhancing. A cyst with an enhancing mural nodule is highly diagnostic of pilocytic astrocytoma in the posterior fossa, especially in children. And you see the incidence is in between the age of 5 to 15 years old, and it represents about 2 to 6% of the primary brain tumors. Then, if you see a cyst with an enhancing mural nodule, then you consider pilocytic astrocytoma in the posterior fossa, regardless the size of the nodule or the site of the nodule. The nodule may be on the inner wall of the cyst and may be located in a septum inside the cyst itself. And this is a good example of a pilocytic astrocytoma. There is a big cyst in the left cerebellar hemisphere with an enhancing mural nodule, and the cyst is compressing the fourth ventricle with consequent supratentorial obstructive hydrocephalic changes. And this is a good example of pilocytic astrocytoma by MRI T1 weighted image and T2 weighted image and T1 post contrast. In here, you can see the cystic component and the solid component, which is large, showing contrast enhancement, and the solid component appear of relative intermediate signal in the T1 and high signal in the T2 weighted images. And the lesion, which is exactly similar to pilocytic astrocytoma, is the hemangioblastoma, and there are many differences between both lesions. By brain imaging, you see a cyst with an enhancing mural nodule exactly similar to the pilocytic astrocytoma. But the hemangioblastoma occurs usually in adults, while pilocytic astrocytoma is occurring in the pediatric age group. Number two, the hemangioblastoma, the nodule is hypervascular, and if you have an angiogram, and you should see a tumor blush corresponding to the mural nodule of the lesion. But the mural nodule in the pilocytic astrocytoma is hypovascular and does not show any tumor blush in the angiogram. Also, the angioblastoma have an intimate relation to the von Hippel-Lindau syndrome, but the pilocytic astrocytoma do not have this relation. Also, hemangioblastoma can occur in multiplicity, but the pilocytic astrocytoma do not show this feature. Then the hemangioblastoma occurs usually in young and middle-aged adults, and this is the age incidence between 30 to 65 years of age. And this tumor is rare in children, is commonly seen in the cerebellar hemispheres, but can occur also in the spinal cord. The pilocytic astrocytoma can occur also in the spinal cord. And this is a good example, and you see here a cyst with an enhancing mural nodule, which cannot be easily discriminated from pilocytic astrocytoma, especially if the age is not helpful. Then here you see a cyst with an enhancing mural nodule. This is the cyst, and this is the mural nodule, which is enhancing. And this is the sagittal T1 post contrast, and this is an angiogram. In the angiogram, you can see this tumor blush corresponding to the nodule, indicating that this nodule is hypervascular. Then you can diagnose the hemangioblastoma. Then about 35 to 60% of patients having von Hippel-Lindau disease will have this hemangioblastoma. And this is the T1 weighted image before contrast injection and after contrast injection. The nodule is of intermediate signal here, and it shows intense post-contrast enhancement. And this is an example of a patient with von Hippel-Lindau syndrome having three medulloblastomas, hemangioblastomas, I'm sorry. And then this is one hemangioblastoma, and this is another one, and this is another one. And one of the important features here is that the cyst of the hemangioblastoma may be too small so that you cannot appreciate because the nodule is almost totally filling the cyst itself. And if you see a lesion which is classic of hemangioblastoma like this one, having two mural nodules, and you see a solid, a homogeneously enhancing lesion nearby, then you consider this is another hemangioblastoma, but you are not able to see the cyst because the cyst is totally occupied by the solid component. Then in order to diagnose von Hippel-Lindau syndrome, you should have one of three criteria. Number one, the patient had multiple hemangioblastomas like this one, or the patient had a hemangioblastoma with a positive family history for the same disease, or the patient had a hemangioblastoma and also he has some visceral tumors like the tumors in the kidneys, tumors in the pancreas. And this is the stigmata of von Hippel-Lindau syndrome. In the cerebellum, you may got hemangioblastoma, and also in the spinal cord. And this is a retinal angioma, and also the endolymphatic sac tumors near the vitreous bone. Pulmonary hemangiomas are one of the components, and hepatic hemangiomas as well. Then you got multiple pancreatic cysts or pancreatic hemangioblastoma, and then the suprarenal gland, you may get pheochromocytoma, renal hemangioblastoma, or renal cell carcinoma, or multiple renal cysts, and you got in the ovary or in the adnexa bilateral papillary cystadenoma of the broad ligaments, and in male patients you may get bilateral papillary cystadenoma of the epididymis and also epididymal cysts. And the final lesion in this group is the trigeminal schwannoma or neuroma, and this lesion occurs along the course of the trigeminal nerve. You know that the nerve comes out from the brainstem, it goes into the cerebellopontine angle, then into the exits, then goes through the skull base foramina, reaching the paracellular area, and in its destination here in the Gisserian ganglion, which is located in the Meckel's cave, which lies posterior to the cavernous sinus. And this is the second most common intracranial schwannoma after acoustic schwannoma, and it presents by facial pain, weakness of the muscles of mastication, and the tumor follows the course of the nerve, as I have mentioned. Then you have a constriction in the middle part of the tumor while exiting through the foramina, and you got two main components giving the typical or the classic dumbbell configuration of the lesion. And in order to diagnose trigeminal neuroma, the first sign is that you cannot identify the Gisserian ganglion separable from the tumor. This is the normal Gisserian ganglion found posterior to the cavernous sinus, but on the site of the tumor, you cannot see the Gisserian ganglion. If you see the Gisserian ganglion adjacent to the tumor, then think of other diagnostic possibilities like paracellular meningioma, for example. And this is a trigeminal neuroma. And the second diagnostic criteria is the dumbbell configuration. You have two components of the lesion, one infratentorial and one in the supratentorial. The third feature is that in the coronal images, you can see the tumor extending through the skull base foramina. And here is the component of the tumor, and this is an intracranial component of the tumor. Then we came to the supratentorial tumors. Actually, not all the tumors occurring in the adult population are seen in the pediatric age, but I will show those uh, who can be seen in the pediatric age group. And this is one of them, which is known as the pleomorphic xanthoastrocytoma or BXA. And this tumor is exactly similar to the pilocytic astrocytoma, but occurs in the supratentorial area. And you see a big cyst with an enhancing mural nodule. And this lesion do not occur in the posterior fossa, but occur supratentorially. And one of the best diagnostic landmarks for this tumor is the nodule should be superficially located on the surface of the brain, whether this is the lateral surface of the brain or the medial surface of the brain. But the nodule is not seen here or here. It should be seen on the surface of the brain, and this is one of the diagnostic criteria. This is an example by CT and MRI, a cyst with a mural nodule, and the nodule is on the surface of the brain, the medial surface of the brain. And this is also a good example by CT and MRI. There is a cyst and there is a mural nodule containing some calcium, but very importantly that the nodule is superficially located, touching the surface of the brain, whether it is the lateral surface or the medial surface of the brain. Then the glioblastoma multiforme, the most aggressive type of the gliomas, can occur in adults and also in the pediatric age group. The diagnostic landmark here is the presence of a heterogeneously enhancing lesion surrounded by extensive perifocal brain edema. These are two different examples. You see here tumor with non-enhancing areas representing intratumoral hemorrhage and necrosis, which are features of this type of glioma. And you can see the extensive perifocal brain edema around the tumor, compressing the lateral ventricle, which is totally collapsed. And there is some displacement of the midline structures, as also you can see here. And this is an example of glioblastoma multiforme and by MRI T1 weighted image and T2 weighted image and T1 post contrast. This tumor shows low signal in the T1 and the high signal in the T2, and you can see some high signals in the T1 weighted image representing intratumoral hemorrhage. The tumor, if it occurs in this particular anatomic area, it can easily grow through the corpus callosum and extend into the opposite side. And this is the glioblastoma multiforme by MRI T1 weighted image showing heterogeneous post-contrast enhancement. Similar to any other tumor, it will show low signal in the T1 and high signal in the T2. And you got intratumoral high signals in the T1 weighted image representing intratumoral hemorrhage, which is one of the criteria of this tumor. And after contrast injection, it will show heterogeneous pattern of contrast enhancement. And this is a big glioblastoma multiforme in the T1 weighted image, and this is T1 post contrast. In the T1 before contrast injection, these foci of high signal representing the sites of bleeding, and the tumor here is showing heterogeneous post contrast enhancement. In gliomatosis cerebri or infiltrating glioma is a rare tumor which infiltrates the substance of the brain and it does not enhance after injection of contrast. So in the CT scans you cannot see the tumor itself either before or after contrast injection, but you see its mass effect on the ventricle. And here you see this area there is compression of the lateral ventricle, but you cannot differentiate the gray or the white matter. Look at the frontal lobes bilaterally, you can see the white matter and the gray matter. But in this particular area, you cannot see the gray-white matter differentiation because they are totally infiltrated by the tumor. But if you have the MRI images, especially in the T2 and the FLAIR-weighted images, you can see the infiltrative characters of this tumor compressing the adjacent ventricle. then this tumor is not seen by CT and not seen by MRI T1 weighted images. But if you have the T2, you can see the tumor showing a high signal, and in the FLAIR images, you can see the tumor showing a high signal. If you inject contrast, the tumor will not enhance with contrast media. And if you have the diffusion weighted images, the tumor will not show restricted diffusion. And this is an example. You see that the right lateral ventricle is not there. It is compressed by an infiltrating lesion somewhere in this area. In the T2 weighted image, and you can see the faint shadow of the tumor in the parietal area of the right cerebral hemisphere. And after contrast enhancement, you cannot see any contrast enhancement within the tumor. Metastases in the pediatric brain are not commonly seen like those metastatic deposits in adults, but in cases of neuroblastoma, for example, which is one of the lesions commonly seen in our bracts, and the metastatic deposits have certain definitive criteria, being located at the suture line, and they result in marked widening of the suture. And in these areas, you see a mass which is most likely homogeneously enhancing. It has an intracranial component, and many times it also has an extracranial component. And these lesions occur commonly near the orbital cavities, and they encroach significantly on the orbit, resulting in evident proptosis as well. Then this was the first part of this lecture. Thank you very much, and we will continue the second time after that. Thank you.